Welcome to Washington Unplugged. I'm John Dickerson. Why are Wall Street banks getting the H1N1 vaccine when it's so scarce? Earlier this week, Business Week reported that they are, despite widespread shortages for high-risk groups. Congressman Frank Pallone, chairman of the House Energy and Health Subcommittee, announced yesterday that he'll be holding a hearing to get to the bottom of this. He joins me today. Hello, Congressman. I want to start right away with what you're hoping to figure out from the hearing you've got scheduled for the 18th of November.
Well, the hearing is about the distribution and production of the vaccine in general, the concern about it's not getting out to people fast enough and who it's getting out to.
The vaccine is still created using methods that come from way in the past, from using egg yolks.
Right.
Why is that, and what's the alternative to that?
There doesn't seem to be a good alternative, and that's why it's hard, I guess, for the government or the manufacturers to know exactly how much vaccine is available at a given time. But we still want to make sure that it is distributed fairly.
It was no surprise that that's the way they make the vaccine, and so shouldn't people have been able to anticipate that this would take a little bit of time?
Well, my understanding is that you never know when you're producing the vaccine through these eggs exactly. So they anticipated a certain amount available a certain day, but it is a process that doesn't have, mathematic exactness to it.
On the question of these Wall Street banks that got vaccines, what's your understanding? Were they unfairly, did they get an unfair advantage here?
Well, that's my concern. I mean, look, if the city or the state decides to distribute it to, large companies because they have a health clinic, then that means that a lot of companies or employees who don't have a company that's, really up to it and really being aggressive to get the vaccine won't get it. And I don't think it should be distributed that way. Who's the most aggressive? Who has the most clout?
And so in your sense is that it is a question of clout and aggressiveness as opposed to, say, just the fact that they're enormous employers. In addition, say, to Goldman Sachs, you also had New York University, which doesn't have the kind of, at least financial clout that Goldman Sachs has.
Right, but the larger the company, the more likely they have a health clinic and an aggressive program. So, just because they're large and that they're doing a good job in promoting and getting the word out and applying for this, that shouldn't be the basis for the distribution. It inevitably means that those companies or large outfits that are the most aggressive and they're the ones that are going to get it, and I'm concerned about that.
And is it your sense that they were aggressive in dealing with local city officials? How does the chain work here, or is this something that the federal officials are on the hook for as well?
Well, the federal government has left it up to the states, and in the case of New York, I guess they left it up to the city. That might have to change, but in any case, I don't think that it should just be based on who applies, because naturally, a company like Goldman Sachs or Citicorp is more likely to be aggressive than some smaller company that doesn't have a health clinic or is not paying a lot of attention.
I want to ask you a general question. Conservatives have taken the delay in the distribution of the vaccines and tried to make the case that this is exactly what would happen with a public option or some kind of government role in expanding health care. What's your answer to that?
Well, that's absurd, because basically what the health care reform does is to set up a health exchange that includes mostly private insurance companies, and the public option is just one option. So if the public option doesn't do a good job, people won't choose it. People have a choice and there's competition.
Now, I'll take another hot button issue here as the last question, which is that in speaking to public health officials, they've said, because this pandemic affects people regardless of their ethnicity or their wealth or any other reason, that illegal immigrants should be vaccinated if they're in these high-risk groups. What's your view on that?
Oh, I think that we should do the vaccination strictly based on whether it's a high-risk group, because, disease has no barrier based on whether you're documented or not. And if you end up not inoculating people who are undocumented and they start spreading the disease, then that hurts everyone. So just from a practical point of view, it should be done based on who's the highest risk, so as we don't have the disease spread.
And what about, though, the politics of that? Somebody might say, well, why is this person who's here illegally getting something that should be going to, American taxpayers? Yeah,
but that's acting against your own self-interest. I mean, that's like saying, well, all the poor people have a disease, so we won't inoculate them, and somehow the rich people are going to be immune. Well, it doesn't work that way. So, I mean, I think you've got to be practical about this and not worry about whether somebody has papers.
Okay, Congressman, thanks very much for being with us. Dr. Anthony Fauci is director of the National Institute of Allergy and Infectious Diseases in Washington. He joins us now from their studio to explain the latest on the vaccine shortage. Doctor, I want to start with you first about just this delay. The techniques used to create this vaccine have been with us for a long, long time. Why haven't they changed, and should they?
Well, they certainly should change, and they're in the process of changing. A few years ago, when we put in earnest the Pandemic Influenza Preparedness Plan, which officially got launched in 2005, the plan was to make a gradual transition from the time-honored but somewhat fragile technology of growing up the virus in eggs, then purifying it, inactivating it, and then getting it to a form where it's a vaccine is totally dependent upon how well the virus grows in eggs. And we knew for a long time, and everyone knew, but it was time-honored, and it was a situation where people did not have the incentive to move to the next level and to bring it into the 21st century. That started a few years ago. We're in the process of making that transition, but at the point in April when it became clear that we needed to make a vaccine for this new virus, this H1N1 pandemic influenza, there was no other technology available except this time-honored but somewhat fragile technology. And what's happened is that the virus is growing rather slowly in the eggs, and that happens sometimes. Sometimes you get growing virus that looks really good, it grows very well. So that's the fundamental issue. The other issue, if you look at the time frame, we make this exactly the same way that we make seasonal influenza vaccines. Usually around January, you know what's going to be in the strain for the following fall and winter, and you start making it in January. It takes about 6 to 8 months to make, and then you start getting it ready to ship. You ship it at the end of the summer, the beginning of the fall, and you usually have a cushion of a few months because we don't usually see seasonal flu in earnest until the late fall and through the winter. So even though you have a process that is fragile and subject to some uncertainties like rate of growth of the virus, you still have some cushion on either end that if it's slow, you don't really have to have it immediately at the end of August or the beginning of September. We had really a triple whammy here because the virus itself only became known to us in April, so you're already 3.5 months behind when you would normally start for a seasonal flu. The flu, the pandemic flu, never left in the summer. So as soon as the kids came back to school at the end of August and the beginning of September, you had a major surge, which we're still seeing. So there was no wiggle room or leeway, and you superimpose upon that this technology of which we had no other choice but to employ for this season. And you had the situation we're in now, which is the unfortunate gap between supply and demand, which is beginning to close now, but still it's unfortunate and frustrating for all of us that we have this gap.
That technology, the improved, newer technology that might be a little faster, I was led to believe that in Europe they actually do use a technology that's a little bit faster, but we're nervous about doing things outside of the country. Is that right? Could there have been European vaccine manufacturers that could have gotten this faster?
Actually, only partially and slightly partially correct. There are some companies that are making the transition and have done so well to what we call cell-based. Instead of growing it in the eggs, you grow it in cells. You still have to grow the virus. That's the point. Most of the doses that are being distributed throughout the rest of the world are vaccines from viruses that were grown in eggs. So it's a misperception that the rest of the world is doing something that's not egg-based and we're the only ones that are doing that. That is a total misperception. We are, by our investments with many of these companies, trying to push the envelope to make the transition from egg-based to cell-based, but the real end game is to get away completely from having to grow the virus in order to get a vaccine. It's to use the 21st century molecular biology, recombinant DNA technologies, so that you can get lots of purified protein without growing the virus. That's really the ultimate end game. So what we're going to be seeing over the next few years is a transition from egg to partially cell-based, and then a transition into the real avant-garde type of technologies, which will get away from all of this uncertainty. And a lot of investments were made over the past few years to do that, investments to the tune of hundreds of millions, if not billions of dollars.
So next time, let's say next year, how much further down the road and faster on our feet will we be to combat this kind of thing?
Well, you know, it's tough to say. What the companies and others are going to have to do is that they're going to have to get the cell-based material, apply for a license from the FDA, and see if we can make that transition. I don't think, and I'm fairly sure of this, that we are going to have an absolute abrupt transition from total egg to total cell-based. It'll likely be a transition that will go into next year, and then in subsequent years, you'll see very likely the cell-based take over until the new molecular technologies come in a few years down the pike.
So if in this case we have the technology is a little slow, and then we had those other factors that humans couldn't control in terms of when this showed up, where else would you look in terms of the response to this that could be improved for the next time this comes around?
Well, you know, one of the things that we really should point out is that this is the first time literally in history that there has been vaccine available, although there's a gap between supply and demand, for a virus that's a new pandemic virus. We've never had that before. We're all frustrated by the gap. But the good news about it is that we've never been in a situation where we've actually had a vaccine that was there, albeit not in the amounts that we want, for an influenza pandemic. What can we do better the next time? I think we're going more and more in the direction of being able to have a technology that is more reliable. Unfortunately, we're not there right now.
We just had a conversation with Congressman Pallone, and he suggested that because this pandemic crosses all boundaries of ethnicity, age, and wealth, that even illegal immigrants should get the vaccine if they're in that high-risk group. What's your thoughts about that?
Well, I mean, when you vaccinate people who are in our country, you go another step towards preventing the spread. As a physician, as a public health person, it doesn't matter to me who those people are. You're trying to keep the level of infection in the community down. So when you vaccinate people, you do two things. You protect the individual themselves, and you also, by protecting that individual, prevent that person from spreading it to someone else. So you shouldn't look at it in terms, in my mind, as a public health person, immigrant or non-immigrant. You look at all of society, and you want an individual benefit and a community benefit.
Let me ask you another public health question related to this, which is we're obviously in the middle of a big conversation about universal health care. This, in terms of pandemics, does it help make the case for universal health care, leaving aside the way in which the vaccine was rolled out this time? Does it make a case for universal health care in terms of having a system in place where people can move faster when confronted with this kind of pandemic?
Well, I'm not a universal or not universal healthcare expert. My expert is in biomedical research, but as a health person, the more people who have access to care, obviously, the better your effect is going to be on the broader community of containing something like an infectious disease epidemic or pandemic. So it's just a logical extension that if you can get to people who need health care, you're going to do a better job.
Okay, Dr. Anthony Fauci, thanks very much for being with you. It was a pleasure.
Good to be here.
Thank you for watching Washington Unplugged this Friday. Don't forget to tune in Sunday when Bob Schieffer hosts Face the Nation. See you next week. I'm John Dickerson.